Buenos dias and good morning everyone. My name is Putra Vatakal. I'm very honored to be invited to speak here today. I also thank Dr.BanchaC who is my teacher and one of the reasons that I'm here talking to you. Now let's talk about multi-directional shoulder instability. These are some of the key concepts we'll be talking about. We'll start with multi-directional laxity or MDL and how it's different from instability or MDI. Laxity without pain is not so much of a problem. It's when laxity becomes painful that we call it instability. Individuals with MDL or laxity have hypermobile joints that may sublux or dislocate quite easily with minimal trauma, but they are also easily reduced and don't cause too much trouble. MDI or instability is when hypermobility comes together with pain. There is hypermobility in at least two directions, inferior and anterior or inferior and posterior, and sometimes in all three directions. And especially where operative treatment is concerned, we'll see that this often comes in the form of structural tears, for example of the labrum. In the 1990s, Pagnani and Warren classified patients with MDI into three groups. Those that were born loose, and this is often called true MDI. Those that are torn loose, which implies a traumatic labral tear, and acquired loose, which are often due to the repeated micro-trauma of abduction external rotation movements. Now it's important to realize that in most cases these patients all started out as MDL or laxity, but over time as they started to feel pain, they come to see us with instability. Type 1 MDI or born loose patients usually have a collagen disease like Ehlers-Danlos or Marfan syndrome and generalized ligament laxity. This causes a global instability. It's good advice not to operate on these patients because usually whatever you try to do, it will end up failing. You can see the many surgical scars on this patient's shoulder, and despite capsulolabroplasty and even later a Latarjet procedure, her instability has not gone away. So it's best not to bring these patients to the operating room at all. Type 2 or torn loose patients are patients with MDL that develop instability either by repetitive trauma or a severe single trauma, which is why you will see this more in overhead contact sports like basketball, handball, and rugby. These patients have developed capsular redundancy plus a labral tear. This type of patient responds well to surgery. Type 3 or acquired loose patients usually develop capsular redundancy without a labral tear, often due to repetitive microtrauma in non-contact sports like swimming, racket sports, baseball, or gymnastics. These patients also respond well to surgery. Another situation to consider is MDI with posterior instability. We divide these patients into those that dislocate voluntarily and involuntarily. The voluntary dislocators can be positional, which means the shoulder dislocates in a certain position, usually flexion, abduction, and internal rotation. These patients usually do not need surgery. Voluntary muscular dislocators are not positional dependent and are contraindicated to surgery. The involuntary dislocator is seen here, and you can see that just lifting up her arm results in posterior instability. They often need surgery. When examining patients with MDI, we start out with a more comfortable laxity tests. Here you see the anterior and posterior drawers tests. This is the sulcus sign, which suggests inferior laxity. The hyperabduction test, which is positive at more than 105 degrees, and the Baton score. The painful instability tests are done later. Here you can see Dr. Bancha doing the anterior apprehension test at 45, 90, and 135 degrees to test the anterior and anterior-inferior labrum. The posterior apprehension test, which together with the painful jerk test examines the posterior labrum. Kim's test that evaluates the posterior inferior labrum, and O'Brien's test for the superior labrum. The next question is naturally what to do. As good surgeons, we always start with conservative treatment, of course. Pain control and strengthening of the muscles around the scapula, followed by rotator cuff strengthening, pilometric strengthening, and sport-specific conditioning. Many patients are quite happy with their improvement after about 6 months of rehabilitation. Surgery can be considered after a failure of conservative treatment for at least 6 months. Our surgical goals should be to restore labral height, to tighten the joint capsule, and to balance loose ligaments. We prefer to use a supine position, which is useful because you don't have to move around the patient and it's quite ergonomic for the surgeon. We use the same 3 portals for nearly all instability surgery, starting with the posterolateral or Kim's portal around 1 cm from the posterolateral corner of the acromion, followed by the anterior superior portal just below the AC joint and the anterior inferior portal just above the subscap tendon. We use 3 cannulae to make life easier. First, we assess the labrum, specifically looking for any hidden lesions, like the concealed Kim lesion. The repair site is freshened, and the repair starts from the 6 o'clock position using a double-loaded anchor. We should start at the 6 o'clock because most patients have a component of inferior instability. The repair is done from 6 to 3 and 9 o'clock anteriorly and posteriorly. And finally, we close all the defects in the shoulder, including the rotator interval at 45 degrees, and lastly, the posterior portal is closed to complete the procedure. We have been looking at a type 2 case with a labral tear, but sometimes in type 3 MDI, there is no labral tear. Here we recreate the labrum by detaching it from the glenoid, followed by a capsulolabroplasty. We prefer this over a capsular plication because it addresses both labral height and the redundant capsule. And just so we don't forget, let's remember this young lady with voluntary muscular type 1 MDI. This was her X-ray when she first came to see us. I don't think there's any procedure that was not tried, but nothing worked. Everything failed. This case is a good reminder for me to take a detailed history and examine for generalized laxity before taking my patients to theatre. So to conclude, let's remember, MDL or laxity is different from MDI. MDI or instability is when the patient has laxity with symptoms. Never do surgery in patients with congenital MDI, and remember the indications for surgery: involuntary dislocators and MDI patients with a labral tear who have failed at least 6 months of non-operative treatment. Gracias and thank you.